Second lecture, exoskeleton spine. Today, we complete our first lecture, starting by cervical spine injuries. The patient is usually give a history of falling from a height, or diving accident, or an vehicle accident, in which the neck is forcefully moved, either in flexion, horizontal extension, and so on. In a patient unconscious from a head injury, a fractured cervical spine should consider anteroprobe otherwise. I means any case with a fracture or with head injury should take in consideration the possibility of cervical spine injury. And an abnormal position of the neck is suggestive. Also, careful palpation may be less tenderness in those patients, especially in the posterior aspect of the neck regarding the cervical spine. By palpation or tapping on the tip of spinal processes, we can less tenderness and pain, which is indicate injury of the spine. The neck is fixed usually in such a condition by a collar, which either soft or rigid, and the commonly used rigid collar. Other way of immobilization of cervical spine by sandbag or by strapping on the frontal part of the head to the stretcher. Other policy of immobilization of cervical spine in the hospital by using of tongue or hollow ring, or internal fixation by a screw on the blade or screw or K-wires. This is by operative fixations. Here we see, you can see the cervical spine injury, the ecchymosis on the head and on the neck, and here type of the collar, and here use of the hollow body cast with this bar and immobilization of the neck with the tongue in the head, and so. How we evaluate the cervical spine injury? Usually by using X-ray. And X-ray, AB and lateral view, these are the commonest views to be used. And we have also flexion and extension view, and left or right pillar view or oblique view. In lateral view, usually we use 4 imaginary lines on the spine to see the alignment or any deviation from the normal alignment. These are 4 lines, one of them in continuity of the anterior border of the bodies of vertebrae. Here you can see this is the line. There is no interruption of this line, smoothly coming down from C1 down to the C7. The second line is on the posterior surface of the body, and the third one in the posterior border of lateral masses. This is one. And the fourth one is the base of the spinous process. These are 4 uninterrupted lines. 4 uninterrupted lines must be shown on X-ray to see the normal alignment of the cervical spine. Now we started region by region of injury of cervical spine. First one is the occipital condyle fracture. As you know, the skull articulates with the atlas by the occipital bone through its 2 condyles. This is usually a high energy fracture associated with the skull or cervical spine injury usually, and it occurs when there is the head by a heavy object from above and so on. Diagnosis is likely to be missed on X-ray because it is hidden area underneath the skull. So CT scan here is essential. Impaction or undisplaced fractures can be treated by breast immobilizations for about 8 to 12 weeks. Displaced fractures are best managed by using a hollow vest or by operative fixations. C1 fracture was called Jefferson fractures. Sudden severe loading on the top of the head may cause bursting force which fracture the ring of the atlas. As you see, the ring of the atlas here, atlas vertebrae. This is the articulation, superior articulation with the condyle of the occiput, and here the ring, and here the transverse process with intertransverse foramens, and here the anterior and posterior part or arch. There is nobody in the atlas, and because of the pressure here, loading force here from the head downwards might lead to burst fractures here of the arch, commonly anterior and posterior arch fracture, and sometimes bilaterally. And here it is difficult to visualize by routine X-ray, so usually we use the open mouth view. Open mouth view through the oral cavity, we can see the two masses of the atlas and see the separation of these masses. Instead of separation of these masses, we can evaluate the fractures. So there is no encroachment on the neural canal and usually no neurological deficit, because here you see there is a wide area, and because the burst fracture, the force displaced the arch of the bone away from the spinal canal, here the spinal canal. So there is no encroachment on the spinal cord here. Even it is dangerous area to be injured here, because in the area of C1, C2, C3, we have the respiratory center or the phrenic nerve supply from C2, 3, 4. Here. Displaced fractures are best managed by using a hollow fist or by operative fixations, while impact fractures treated by a brace, just immobilization, by rigid collar or something like this. Okay. The simple fractures was called Jefferson fractures. Jefferson fractures, it is just displaced laterally, the two arches displaced laterally, and here was called Jefferson fractures. C2 fracture, we have two types of C2 fracture, either fracture of the lymphoid process or fracture of the posterior element, and it was called varus interarticular fracture. Here it's called Hahnemann fracture. There are bilateral fractures of the varus interarticular of the C2 or C2 C3 disc is torn, and the mechanism is extension with distractions. Extension and distractions hanging. So this is one cause of death in motor vehicle accident when the forehead strike the dashboard or the glass wood. Well, they hit on the front of the head and do a hyperextension with distractions or with extensions. Neurological damage, however, is unusual because the fracture of the posterior arch tends to decompress the spinal canals, displaced posteriorly. Nevertheless, the fracture is potentially unstable, so might lead to the lethal problem. Undisplaced fractures, which are shown to be stable on the supervised flexion extensions, views less than 3 mm of C2, C3 subluxation, can be treated in a C-rigid collar, and that's all usually for about 6 to 12 weeks. Fracture with more than 3 mm displacement, I means C2, C3 subluxation more than 3 mm, but no kyphotic angulation, may need reductions. However, because of mechanism of injury usually is involved distraction must be avoided. Here, keep in your mind this important point of view, that is because the mechanism of injury is hyperextension with extraction or distractions. So the traction is contraindicated because traction means the same mechanism of injury. After reduction, the neck is held in a hollow fist until union occurs. About on the C2 C3 fusions is sometimes required for persistent pain and instability. Traumatic spondylolisthesis is called traumatic spondylolisthesis. Occasionally, the Hahnemann fracture is associated with C2 C3 fascial dislocation. This is a severely unstable injury, and overdosing and stabilization is required. Here you see the Hahnemann fracture in the posterior element, and this is the posterior element going posteriorly. So there is separation of the canals or of the spinal canals, more space for it. You see it on X-ray. Unless it is unstable, it is usually not so severe injury, not so lethal, unless it has element of instability. So you see here the anterior part of the axis. This means the facet joint and the auditory process articulate with the atlas, while the posterior elements go with the C3 and space posteriorly. It's like a spondylolisthesis. Here deviate anteriorly and here deviate posteriorly, like spondylolisthesis. C2 auditoid process fractures. This is second type. It's uncommon. This usually occurs as a flexion injury in the young adult after a high velocity accident or severe falls. However, they also occurs in elderly osteoporotic peoples as a result of the low energy trauma in which the neck is forced into hyperextensions. Core damage is not uncommon. Spinal cord damage not uncommon, and in old people there is a considerable mortality rate. Classification that can be classified according to the site of the crack of fractures, a tip of the auditory process, or the whole dental process, or part of the body with the auditory process. This type 1, type 2, type 3 fracture according to the D'Alonso classifications. Clinically, there is history, or usually that of the severe neck strain, and followed by pain and stiffness due to the muscle spasm, and diagnosis is confirmed by high-quality X-ray. Image: plain X-ray usually shows fractures, and tomography or CT scan can be helpful. MRI has the advantage that maybe reveal rupture of transverse ligament, and this can cause instability in the abscess of the fracture. MRI, as you know, reveal the soft tissue, so it may reveal rupture of the transverse ligament, and the lumbar transverse ligament, which is circle the odontoid process and keep it attached or articulate with the anterior part of the body of the atlas. Okay. Here the fracture and the X-ray pictures. You see it. Anterior open mouth X-ray, type 2 odontoid process fractures. Here, see, like this one. Here, shearing force, cut of the odontoid process. Okay. We finished the C1, C2. Now coming with lower cervical spine from C3 and C7. These are usually they are same or same structure or anatomical similarity of these vertebrae. So the injury of each one like the others. Posterior ligament injury, sudden flexion of the mid-cervical spine can result in damage to the posterior ligament complex, which are consist of the interspinous ligament and supraspinous ligament and lateral and left and right interspinous ligaments. These are damage to the posterior group of this ligament complex. Facet capsule also and facet capsule and supraspinous ligaments lead to the rupture of them, leading to the instability of the cervical spine. The upper vertebrae tilted forwards on the one below, opening up the interspinous space posteriorly. The patient complains from pain, and there may be a localized tenderness posteriorly. And here we mention by examination we palpate posteriorly the spinous process and see or palpate or feeling if there is a gap in between. Yeah. The X-ray may reveal slightly increased gap between the adjacent spinous process. However, if the neck is held in extension, this sign can be missed. So it's always advisable to obtain lateral view with the neck in neutral position and sometimes in flexion. Flexion view would of course shows the widening interosseous space more clearly, but flexion should not be permitted if in the early post-injury period. Why? Because this might cause damage to the spinal cord. So take care about doing these views like stress views, flexion and extension views. If it is certain that the injury is stable, a semi-rigid collar for about 6 weeks is adequate. If the injury is unstable, then posterior fixation and diffusion are advisable. Here you see the sulcus one posterior ligament. Here there is a gap, and here widening of the gap and also overriding the vertebra on the above one below. This is mean some sort of subluxation because it sometimes involve only the posterior ligament, but also the facet, and the facet might be override one above the others, leading to the subluxation or dissolution of the facet joint. Wedge compression fractures here. A pure flexion injury results in a wedge compression fracture of the vertebral body. The middle and posterior element remains intact and the injury is stable. And all that is needed is to comfortable collar for about 6 to 12 weeks. Here we have a note of warning that the X-ray should be carefully examined to exclude damage to the middle columns and posterior displacement of the vertebral body fragments. Here, sometimes we have fracture here, compression, and sometimes there is displacement of the piece of the bone to the spinal canals. Must be evaluated properly. Displacement of the vertebral body fragment features of the burst fracture, which is potentially dangerous. I mean, burst fracture of the whole vertebral body might be burst and leading to the fractures. Which is potentially dangerous, and axial CT scan or MRI should be obtained. Burst and compression flexion injury was called teardrop fracture. These severe injuries are due to axial compression of the cervical spine, usually in diving or athletic accident. If the vertebral body is crushed in the neutral position of the neck, the result is burst fracture. With combined axial compression and flexion, an anterior-inferior fragment of the vertebral body is sheared off, producing the eponymous teardrop on the lateral X-ray views. In both types of fracture, there is risk of posterior displacement of the vertebral body fragment and spinal cord injury. The plain X-ray shows either a crushing vertebral body, what's called burst fracture, or a flexion deformity with triangular fragment separated from the anterior inferior edge of the fractured vertebra. That is innocent looking at teardrops. Like a teardrop was called teardrop fractures. Here, there is a piece of the bone. This one was called teardrop. From the inferior part of the vertebra might be fractured. Like a teardrop was called teardrop fracture. Sometimes burst fracture, the whole body involved, or sometimes the part of the inferior part of the vertebral wall is called teardrop fracture. CT scan MRI should be performed to look for the retrobulging of the bone fragment into the spinal column. Treatment of these conditions: if there is no neurological deficit, the patient can be treated surgically or by confinement to bed and tractions for about 2 to 4 weeks, followed by further period of immobilization in a hollow fist for about 6 to 8 weeks. The hollow fist is unsuitable for initial treatment because it does not provide axial tractions. If there is any deterioration of the neurological status while the fracture is believed to be unstable and the MRI shows that there is a threat to the of the cord compression, then urgent anterior decompression is considered in anterior corbectomy, bone grafting, and plate fixation, and sometimes also posterior stabilization needed. Fracture dislocation. Bilateral facet dislocations are caused by severe flexion or flexion rotation injury. The inferior articular facet of one vertebra rides forwards over the superior facet of the vertebra below. This is called dislocations. The lateral X-ray will show forward displacement of the vertebra on the one below. If it's greater than one half anterior posterior width, it is either incomplete or complete. Less than half displacement mean unilateral. More than half displacement usually it is a bilateral dislocation. MRI can diagnose the fractures. Treatment. It may be more convenient to immobilize the neck in a hollow fist for about 12 weeks. Another alternative is to carry out posterior fusion as soon as reduction has been achieved. The patient is then allowed up in a cervical brace, which is worn for about 6 to 8 weeks, and posterior over-reduction and fusion is also indicated if close reduction fails, and in unilateral facet dislocation on the lateral X-ray, the vertebral body appears to be partially displaced, less than one half of the width, as we mentioned, and if more than half of the width displacement mean bilateral dislocations.